Hi, Courtney DiNardo here from MD Anderson in Houston, Texas. And it is my privilege to provide just a quick update on the long-term follow-up of the VIALE-A data. And there will actually be two oral abstracts that'll be presented at ASH that will go through some of these updates. In particular, Keith Pratz will be presenting the specific long-term follow-up. And I think what is important about that abstract is the finding that, of course, patients still continue to show an improved overall survival over time in patients that have received azacitidine and venetoclax compared to azacitidine alone, AZA with placebo. The median survival, of course, hasn't changed, and that's been presented before. But the finding that patients who obtained a composite remission, so a CR or a CRI, which again was about 2/3 of patients, those patients on average remain in a remission for about 2 years, and I think that is clinically meaningful. One thing I think that is important for our field to realize, though, is the fact that very few people are actually cured with this regimen. And so I get that question a lot: should we stop therapy? And I don't recommend that we stop therapy. I think this shows that in patients who don't go to transplant, very few patients on VIALE-A followed with transplant, that responses and survival is improved with aza-ven, but unfortunately this is not a curative regimen. So that's why we are still interested in moving the field forward and evaluating novel triplets and other combination therapies. The other thing that I think is incredibly important, and this is what Dr. Doner is presenting, another update of the VIALE-A data, is he looked at the risk classification, looked at whether the ELN stratification was prognostic in patients receiving aza-ven. And actually the most important features for patients receiving aza-ven in terms of improved overall survival were just a few mutations. So splicing factors were not particularly important. The things that were important, patients with P53 mutations, as we know, unfortunately had particularly poor survival. Patients who had RAS mutations or FLT3 mutations had intermediate survival, and patients without any of those, so without a P53, NRAS, KRAS, or FLT3 mutation, those patients did incredibly well with a median survival greater than 2 years, greater than 24 months. So I think that really helps highlight patients who have particular benefit with this regimen, and conversely identifies patients with those signaling mutations and often more monocytic phenotypes that maybe we should be looking at kind of augmenting therapy in regimens I just discussed, various different trials of triplet regimens and maybe cladribine, low-dose Ara-C, venetoclax for those patients. So I hope you found this little mini review informative, and I want to thank you so much for your attention.